Yes, it is live now.
Okay.
Great. So let's wait 1 or 2 minutes to people to join.
No, Dr. Lata, she's just joining. Lata ma'am is just joining.
Sarita?
All are here. We have already gone on live, Vinuta Prakriti.
Yeah.
Ma'am, shall we check your audio as well, ma'am?
Yes, yeah. Thank you. Right.
Thank you, Dr. Lata.
Yeah, Arun, apologies for not being able to speak to you.
No worries.
Yeah.
So I think we can start now.
Yeah.
Okay. Thank you everyone, and hello everyone. I'm Arun, founder of Janitri, and this time we bring you a live webinar on strategies of effective labor management, which is very important to really save the life of mother and newborn during the labor or intrapartum phase. So this time, the South Bangalore OBGYN team is giving that webinar on a different topics like newer concept in labor management, case study discussion, and how to keep our labor ward safe. And so I would like to introduce, and I would like to thank the South Bangalore OBGYN team for that. And let me just share. So we will be covering 15 minutes like newer concept in labor management, which will be given by Dr. Srimati, and then we'll have a 50 minutes discussion on case study, and then 15 minutes by Dr. Sri Lakshmi on performance and protocol in obstetrics emergency, and then Dr. Lata will take the session on how to keep labor ward safe, and then we'll take the question and answer. So I would like to thank each and everyone, Dr. Lata, Dr. Sri Lakshmi, Dr. Vinuta, Dr. Srimati, Padmaja, Dr. Prakyuti, Dr. Sarita, Dr. Reena, Dr. Neelam, and Dr. Bhargavi. The South Bangalore Vision Time doing a great job, and I can see I'm into this field since last 4 years, and I'm following them related to their quality, related to their effectiveness during the whole labor phase and intrapartum phase. Dr. Lata, I think no need to introduce. She is very well-known consultant in this area, and more than 30 years of experience in this field, associated with a lot of NGOs, associated with a lot of companies working on the innovation in maternal and child healthcare, bags a lot of awards. She has conducted a lot of conferences. She has been president of a lot of societies, I think, and very, very welcome, Dr. Lata.
Thank you very much. Thank you, Arun. Thanks.
Dr. Srimati, I've been interacting with her since long regarding our pilot study as well. And she's also a consultant at Rangadore Memorial Hospital. And she has been speaked about a lot about obstetrics and all in different conferences. She actually has a lot of interest into the research, published a lot of paper. And yeah, she's well-known obstetrician here in Bangalore.
Thank you, Arun.
Dr. Sri Lakshmi, she's also a consultant at Rangadore Memorial Hospital. She's also she has a large interest into the vaginal surgeries, high-risk obstetrics, and she's also a faculty in CTG obstetric emergencies. Welcome, Dr. Sri Lakshmi. So to start with, I would like to invite Dr. Srimati, who will be talking about the newer concept in labor management. And Dr. Sri Lakshmi, you please take 15 minutes so we can keep this webinar on time.
It's 20 minutes, Arun. Sorry, the first talk is 20 minutes.
Sure. So yeah, so let's start with the newer concept in labor management. And I request the audience to keep posting your questions on the chat. So we will be having the question and answer session later.
Okay.
Yeah. Can you present your screen?
Yes. Can you see?
Yes. Yes.
Okay. So thank you, Arun, for arranging this webinar and giving me this opportunity. So some
Dr. Srimati, we can't hear you.
hello. Hello.
Yes, we can
Yeah,
hear
I
you.
don't know. Something happened. I'm so sorry.
No worry. Yeah.
Why it went off? Can you see my screen? 1 minute. Sorry. Can you see the screen?
Yes.
Yeah, something happened. Sorry. Yeah. So I'll be speaking about new concepts in labor management, newer and some not so new, but which have not been used in common management. So basically, we'll be covering a bit about antenatal care and, of course, beyond. I think something is happening with my Zoom.
Okay.
We'll just try. Otherwise, you have to give me a few minutes. I might have to change my laptop. I will see how it goes.
Sure.
Okay. So basically, so sorry, guys. Right. Yeah.
Yeah, you can go ahead. Dr. Sri Lakshmi, I think if there is a challenge if you are facing, then we can ask Dr. Sri Lakshmi to give the presentation. So Dr. Srimati is facing some technical problem. So Dr. Lata, can we, like Dr. Sri Lakshmi can go for the next presentation if she is facing a problem?
I should think so, or I could speak on the labor board, how to keep it safe. Yeah.
Yeah. I think if we can talk about.
Just give me a second, because Srimati was supposed to present. I mean, yeah. I'm just going to send the slides across to you. Arun?
Meanwhile, Dr. Srilakshmi
I'm
can talk,
really
right?
sorry. I think I'm back on.
Okay, okay.
Really sorry. I should be just getting the presentation up in a minute.
Is your net okay, Srimati?
No, net is fine, ma'am. I think there was some problem with my Zoom. I don't know why it happened that way. Sorry, really sorry. Just 1 second, I'm just getting the presentation.
Okay.
So quite a large number of them have registered, haven't they? We hope we will do some justice to the topics. Yeah, people from all over the country,
Yes.
have they registered? Yeah,
Yes.
wonderful. Yeah.
Okay.
Yes.
Sorry, really sorry for this unexpected audiovisual problem. So basically, we'll be discussing about new concepts in labor management. As I was saying, some are new, some are old, but which have not been put into practice. So I'll be covering all these in this talk over the next 20 minutes. So first, let's look at how antenatal care is important, purely because if you do not manage the pregnancy properly, you are going to have difficulty in managing the labor also in a very apt way. For example, if you have not managed high-risk pregnancy properly, then your outcomes are not going to be very good. So we know we have all been familiar with the inverted pyramid of care, thanks to Prof. Nicoloids. Now, more and more, we are looking at what is called as an extended inverted pyramid of care, so that we can manage high-risk pregnancies, manage them in the preconception period, so that we can have better perinatal and maternal outcomes. Okay, this is because the first 9 months is very, very important for the rest of the lives. So if you manage the antenatal period very well, you would be automatically able to manage the intrapartum period. So that is why that period is also very, very important. I'm not going to speak more about it. So now let's go into labor. First is preterm labor. Preterm labor complicates about 10 to 15% of all pregnancies. So there is now emerging role for transvaginal ultrasound in the diagnosis of preterm labor, and also fibronectin. But unfortunately, the problems with these are it is not very widely available. But it is important that we are aware of what is emerging now in this field. A single course of steroids, we all are aware, is important. We give it from 24 to 35 weeks plus 6 days. But now what is latest is the American College has come up with a clear, concise recommendation that a single repeat course of steroids can be given to women who are in preterm labor, even if they have had 1 dose of steroids, if it has been given 7 days prior. This you give till 34 weeks of gestation. Of course, nifedipine is accepted for tocolysis for 48 hours so that the steroids can act. There is no role for maintenance tocolysis. There is no role for prophylactic antibiotics, and there is no role for routine bed rest and hydration. So this is what is latest in preterm labor. Repeat course of steroids. Now, the most important thing which is happening now is emerging role of magnesium sulfate in neuroprotection. So it is recommended to all preterm deliveries which are happening up to 33 weeks and 6 days. Okay, so there is strong evidence still about 30 weeks. The NICE has clearly said it can be considered till 33 weeks and 6 days. And this we give as the same dose like we give for preeclampsia prophylaxis for the prevention of eclampsia, like 4 grams loading dose and 1 gram per hour. Okay, so please consider magnesium sulfate for neuroprotection in all preterm deliveries. And if you're planning a preterm birth, say if you're going to do an elective section for severe IUGR, definitely give magnesium sulfate at least for 4 to 6 hours before the delivery. PPROM. Again, we have lots of high-risk pregnancies who then end up having PPROM. So we do give steroids for lung maturity. Antibiotics, the recommendation is erythromycin, but we can give it as per our hospital protocol for a minimum of 10 days. It is important that we monitor the mother and the fetus closely. Tocolysis as a general, recommendation is that we better not give it because we are worried about chorioamnionitis. We can consider expected management till 37 weeks if we monitor the mother and the fetus. Okay, so we do not have to rush in and deliver these babies. We can wait till 37 weeks by doing conservative management. Of course, if they go into labor before 33 weeks and 6 days, you would consider magnesium sulfate in these women. Okay, so please do not rush and deliver all these pre-prom ladies. Give them expected management if we can. Okay, so that is the moral of that. Now, if you look at ruptured membranes at term, 80% can go into labor within 12 hours, and nearly 95% go into labor within 24 to 48 hours. There is a raging controversy. Should we immediately induce them, or can we give them expected management? Cochrane has clearly come up to say that there are no major differences in either of these two, but the worry is chorioamnionitis. So it is important that we monitor these mothers and the babies closely. And if there are no signs of infection and there are no other high-risk factors, we can give them an expected management for up to 12 to 24 hours in select cases. So this again is very, very important to remember. Now, this is a very in thing in using all low-risk women at 39 weeks. This is thanks to the ARRIVE trial, which was published in NEJM in 2018. This is sort of, brought up lots of discussion about whether we should be inducing all women at 39 weeks. This was a multi-center randomized controlled trial, which was done at 41 hospitals in USA. We had about 3,000 women in each arm. And what did they find? If we are going to induce women at 39 weeks, the percentage of women who underwent cesarean section was very low. They were also less likely to have hypertensive disorders, and there was no increase in adverse outcomes for the mother or for the baby. Okay, so now this was followed by a meta-analysis, and the major chunk of these cases was from the ARRIVE trial. So not surprisingly, they came to the same conclusion. By doing 32 inductions, we can prevent one cesarean section. By doing 21 inductions at 39 weeks, you can reduce the chances of having hypertensive disorders of pregnancy. So these numbers are really very good. So now, should we then be inducing women at 39 weeks? Is a question which comes to everybody's minds. But I think one thing we need to remember is whether we can generalize it to all the population and all the centers, because it was done under a strict research guidance in hospitals in America. Now, if you look at the study population, many of them were obese. And you also need to remember, many of our antenatal women, unfortunately, do not have correct dating. So would we then be inducing an early term delivery by thinking that they are already 39 weeks? What is our CS rates? If you look here in the study, even in expected management, the sections was only 20%. Our section rates can go up to 50 to 60%, as we'll be discussing in the case discussions next. So are we then going to be doing disservice? Are we going to be increasing the section rates? Of course, logistics, patient choice, cost effectiveness, these are factors which we would need to be considering. And foremost is, what is a long-term outcome for these children? We know that the brain development, cerebellar development, as you can see, the peak, especially for the cerebellar development, happens sort of towards the end. The maturity happens at 30, 40 weeks. So are we doing injustice? Would we have neurodevelopmental problems happening in sort of childhood and early adolescence? So this is something which we need to be thinking before we take all routine inductions for all women at 39 weeks. Of course, we need to have robust criteria to diagnose failed induction of labor. So if you do not have a good cervical ripening agent, if you're not giving them an adequate induction, then doing induction at 39 weeks is going to cause more problems than benefits. So that is why SMFM has come with clear recommendation. You can offer provided that they meet the criteria for the ARRIVE study research eligibility. So that would be a very handful of patients. So it is important that we watch this space closely and see what is happening. But I think as a rule of thumb, routinely inducing all women, all low risk women at 39 weeks may cause more problems. Okay. There are strict criteria for when we should be inducing women. I'm not going to go into that. It is important that we follow these in order to improve our perinatal and maternal outcomes, especially if you want to decrease the C-section rates. So make sure that we time the induction appropriately as per the maternal and the fetal conditions. Now, let's go into labor because that is going to be the focus. So there is resurging interest, re-emerging interest in vaginal breech deliveries, twin deliveries, operative vaginal deliveries, forceps and ventouse. They have long been a forgotten art, and now people are, looking more and more into resurging this old tools, because obstetrics is an art, and I think it is important that we teach all obstetricians, emerging obstetricians, this important tool of operative vaginal delivery. We'll be discussing more about it in the case discussions, but it is important that we relook at our operative vaginal deliveries, breech deliveries, twin deliveries, because we can reduce our section rates by doing all these things. Now let's go into labor, diagnosis of labor. So this was prior the 1950s. What we thought is we should never let the sun set twice on a laboring woman. This was an age-old concept which we have all been taught in our Mudaliya days when we were doing our post-graduation. It is good, but unfortunately it doesn't give us any idea as to when you should intervene. So then came Friedman in 1950. We all are aware of the sigmoid shaped curve. There is a latent phase of labor from 0 to about 3 to 4 centimeters, after which the slope increases, and then you have a deceleration phase at the end, right? So all our partograms are based upon this Friedman data. So, but what are the problems? Now our obstetric population is drastically different compared to 1950s. We have more women who are elderly, more women who are heavy, increasing use of epidural. We are augmenting more and more women, and of course the babies are more heavier now. And there has always been a controversy. How important is this latent phase? Is there actually a deceleration phase at the end? So all of these things have been always in the background. And they then thought maybe the raising cesarean section rates are because of this. Because if you see, labor dystocia is a cause for nearly 5th or more C-sections, primary C-sections. Why? Because we diagnose active phase arrest as no progress in the active phase for 2 hours. So if there is no progress, we then go for a section. But actually, if you look at evidences, what they found is if you give these women time, 60% of them go on to establish themselves into labor and deliver vaginally. So could we have avoided all these sections? So these are all the problems which made them rethink this Friedman curve. So Zhang came up with this modern labor curve in 2010. So this is based upon the data from 60,000 patients from 19 hospitals in the United States, and they also stratified it based upon the parity, para naught, para 1, para 2. And what they found out, as you can see here, this is a smooth curve, and there is no opening. But what they thought is, based on, as you can see here, there is a sudden increase. So they say latent phase can go up to 6 centimeters, beyond which active phase starts. And as you can clearly see, till about 6 centimeters, both nullep or multip may have the same curve. But once they hit 6 centimeters, the progress is much more quicker in the multip compared to the nullep. Also, they couldn't see any static phase in the end of the active labor, what we call as the deceleration phase. So these are the differences. As you can see, this is a classic sigmoid shape. Here it is a smooth curve, and this varies with the parity. There is no deceleration phase, and sort of around 6 centimeters, the curve suddenly shoots up. So what they felt is we should diagnose active labor only when they reach 6 centimeters. Okay. Now, this was followed by a study by Harper et al. In 2012. They looked at what is the role of induction. So what they found is if you are inducing women, this progression is going to be even more longer, from 4 to 10 centimeters. This progression becomes even more slower in these women who are being induced. This is regardless of whether they are a nullep or a multip. Of course, we are moving from the Stone Age to the Cola Age, our obesity is like coronavirus, it's ever increasing the pandemic. So what is the evidence of obesity? The same thing, what they found, like in induced labors, if the woman is obese, as the severity of the obesity increases, the effect on prolonging the first stage of labor is very notable. As you can see, the curve gets more flattened. Okay, so there is a delay in them getting into active labor, and even in active labor, there is a slight delay in women who are of raised BMI compared to women with normal BMI. So it is important that we factor in induction and the BMI in the progress of labor and not just be thinking everybody in the same box. So this is what SMFM and ACOG came up in 2016 as to how we can prevent primary cesarean delivery. Okay, so what did they say? Delay admission in the latent stage of labor. As you can see in this study, earlier with the admission into the labor ward, higher is the rate of C-section. Say for example, if they are admitted at 1 centimeter, 2 centimeter, the C-section rates are very high compared to later on. So delay admission in the latent stage if possible, and there is no specific upper limit. We used to say 14 hours and 20 hours as a maximum upper limit of latent stage. They say please do not have any arbitrary threshold. Then how do you diagnose active labor? Once they reach 6 centimeters. And if they have reached 6 centimeters and they have had their membrane ruptured, there is no change in the cervical parameters after 4 hours of good contractions, then you call it as an arrest. If they do not have good contractions, give them oxytocin for at least 6 hours before we diagnose an arrest in the first stage. So this is the difference compared to the previous part. There we gave only 2 hours and we diagnosed active labor from about 3 to 4 centimeters. So this is the change which is being brought about now in the mindset of all the obstetricians. And actually this study from Tullier et al. In AMJ-OG has clearly seen using these modern thresholds can actually halve your C-section rates for arrest from 1.8 to 0.9, and it can reduce your overall sections by about a third. Okay, there is no apparent increase in the adverse outcomes. So that is why we would have to embrace this change and use these modern Zhang pathogram as a routine rather than going to the old pathogram. So that is a recent concept. These are not recent, but I think this is important to remember and refresh ourselves because there is lots of evidence to say continuous 1:1 emotional support with a birthing partner has lots of advantages in shortening the duration of labor, decreasing the need for analgesia, increasing the chances of having a vaginal delivery, and having fewer operative vaginal deliveries and sections. It is not going to cost us a lot. Just having an emotional support 1:1 with a partner is going to help the women in a great way. I think we need to encourage this concept of having the birth partner in the labor room throughout and giving them emotional support. Again, routine amniotomy. This has always been thought that if you routinely do an ARM, we can prevent any problems happening in the first stage of labor. There's lots of evidence to say routine amniotomy doesn't shorten the duration of labor, doesn't lower the incidence of C-sections. Yes, if there is a slow progress in labor or if you're inducing women, you might have to do ARM. But otherwise, routine amniotomy is not recommended. Of course, this is a combination which goes hand in hand. Routine amniotomy with oxytocin administration as a preventative strategy. So this again has got no major benefit. Actually, it can have more harms because you can have hyperstimulation causing fetal distress. You can have uterine rupture. Oxytocin is a boon, yes, but it is also a bane. We need to be very careful using oxytocin. Careful selection of cases, examination to make sure that this person, this woman needs oxytocin, closely monitoring the maternal and the fetal parameters when a person is on oxytocin, titrating the dosage with a syringe pump. All of these things are paramount to prevent any problems happening in labor. And if you want to have good outcomes, we need to be very careful in using oxytocin. I cannot emphasize more on that. So this is a recommendation, as I was saying, a prolonged latent stage should not be an indication for C-section, at least 6 centimeters dilatation, and give at least 4 hours in active stage. Now posture. more and more there is evidence coming up to say if the woman does not have epidural, upright or lateral position is recommended. With epidural analgesia, lying down in the lateral position seems to decrease their need for an assisted vaginal birth. Epidural. Our epidural rates are almost nearing 75 to 100%. I think counseling of the couple is very, very important. Anyway, I'm not going to deal with that. But if a woman has an epidural in labor, consider delaying the pushing in second stage. Give them at least 1 to 2 hours before they are encouraged to push, especially in nulliparous women, because it reduces the need for intervention. And again, this is a concept. Once they have hit the second stage, you stop the epidural. This actually will give rise to more problems than actually helping, because the patient is going to be really going into distress. She's not going to cooperate with you. So there is no evidence. Please continue epidural analgesia during pushing as well. And as I was discussing before, oxytocin, use it with caution. There is no role for routine oxytocin augmentation just because the lady has had an epidural. Okay. So now then, how do we define prolonged second stage? We have always thought, if they have had an epidural, give them 3 hours. And if they do not have epidural, 2 hours. That is in a nullep. And in a Paris woman, 2 hours and 1 hour. Actually, American College has now recommended we can even give them longer time if they have had an epidural. They say we can even consider 4 hours of second stage in a primary gravida if she has got epidural. So, but always there is a worry if you're going to give them longer second stage, whether there is going to be problems in the mother and the baby. So far, they have not seen lots of adverse immediate outcomes, but it is important that we give adequate time, at least for a few select patients, so that we can improve their chances of having a normal delivery and decrease interventions in second stage. Of course, considering role of operative vaginal delivery in a few select cases, thinking about manual rotation, all of these things are very, very important. These, obstetric skills are dying and they need to be trained, they need to be practiced, and we will be discussing more about these in the case discussions. Okay, so now moving on from labor. Once the baby is delivered, what do? Again, delayed cord clamping. It's more like an old wine in a new bottle. We have been using it before, but there has been sort of waxing and waning of practices. There is strong recommendation doing a delayed cord clamping both in term and preterm vigorous babies has got lots of benefit for these babies, short term and long term. Okay, so minimum of 30 to 60 seconds, provided there are no contraindications as we have listed. If the mother is unstable, if the baby is unstable, then that's fine. Otherwise, please minimum of 30 to 60 seconds. In fact, NICE says you can even consider milking the cord, though ACOG says we do not know how much milking is going to be helpful. So NICE says if you're in a hurry, you might even consider milking the cord. And most importantly, remember to position the baby at or below the level of the placenta so that you can have gravity helping in the equilibration of the bladder. Okay. So again, this cord blood gases may not be a recent concept, but it is very, very important because it's going to save us medico-legally. Okay. So, do you have to do it as a routine? Again, it's a controversial point. You might say that it's going to be costly, but at least if you're doing a difficult, if you're doing a cesarean section because of concerns with the fetal heart rate, if you are doing an instrumental delivery, or if you have had CTG concerns, if the baby is not well, if the baby has been admitted to the neonatal care, please consider doing cord gases. It's very simple. Just do double clamping, leave the cord. It can be stable for up to 30 minutes. Use pre-heparinized syringes if possible. Don't have any air in the sample, and make sure you get paired arterial and venous sample and take it in an appropriate way. Okay, so that you avoid mixing of samples. Why do we have to do it? It is an objective determinant of the fetal status, but unfortunately it is retrospective, so it is not going to help you plan the delivery, but it is going to be a savior to you if the pH is good, if the base deficit is good. Even if the baby comes in a poor condition, you can save yourself and say, possibly it was not because of an intrapartum problem. So it is going to be a medico-legal defense for you, because metabolic acidosis is very, very important as an evidence to show that there is an intrapartum cause for the baby having hypoxic changes or cerebral palsy. So that is why I think it is important that we obstetricians save ourselves by doing cord blood gases. Okay, so last few slides. So advances and monitoring, we have to embrace technology using, e-patogram. I'm sure Arun is going to be speaking about that. This is going to be very helpful. Having a centralized monitoring. All of these things are latest advances which have come up. And I think these are also very helpful tools in improving the maternal and the perinatal outcomes. So we need to embrace technology. Of course, your job doesn't stop in once you've delivered the baby. Be careful because you don't know when you're going to be getting caught with shoulder dystocia, when the mother is going to have PPH. And as I said, I cannot emphasize enough on cord gases. Of course, postnatally, thinking about VTE prophylaxis, giving them adequate analgesia, thinking about their avoiding dysfunction. These are very, very important. And this is a package of care which we need to give the women. Now, Dr. Srilakshmi is going to be speaking about all of these things, at documentation, debriefing the couple, and if you have had an adverse event, doing an instant form. All of these things are very good in terms of, sort of decreasing medical legal problems as well as saving yourself when you get into trouble. Okay, so in summary, what I would say is preparation, both the patient and the provider. I think the obstetricians also need to be mentally and physically prepared. And in terms of labor management strategies, consider delaying the admission in the latent stage till they are actually in active labor. Think about hydration. Give them, at least clear fluids if there are no other contraindications. Usage of partogram, especially the modern zinc partogram, and if possible, e-partogram, giving one-to-one support in labor. Thinking about different postures, laboring and birthing positions, careful selection and usage of oxytocin, thinking about delayed pushing in nulliparous women with an epidural, and also remember to do delayed cord clamping. I think all these strategies help us to improve our perinatal and maternal outcomes. Thank you.
Thank you, Dr. Srimati, for this wonderful and very crisp session. And I hope participants have really enjoyed it. So without wasting a lot of time, let's move on to the next section, which is a real-time case studies discussion. And this is where people learn a lot. So yeah, I request you to share this slide, and I welcome everybody to participate in this discussion.
Yeah. Okay. So yeah. Just going to be sharing those slides now. Now, can you see them?
Yes, looks great.
Okay. So this is going to be an interactive case discussion. We are going to be discussing a few cases, a few scenarios, so that we can think of and discuss what strategies we can implement to optimize CS rates.
Yeah. So, Srimati, we have been talking about strategies to reduce cesarean section rates. More and more we talk about it, I think the incidence of section rates are increasing exponentially, I would say. And especially in South India, if you can see this particular slide, I mean, Telangana, Tamil Nadu, Kerala, even including government hospitals. Next slide, please. I think even in rural and urban areas, the section rates are increasing. I would say if the WHO is shouting and saying that 15%, the section rates should be reduced to 15%, unfortunately, it is the other way around. We are having 15% of normal deliveries in most of the private setups, especially in the cities, which is rather unfortunate for women and also the babies who are going to be the country's progeny as individuals. Previous slide, please. Yeah, the contributing indications to the rising section rates is mainly overall. There is world over, there is increase in cesarean delivery rate. One of the very important factors is cesarean section at maternal request, and the next one is the primary section causing the problems with the second and subsequent pregnancies. So if the VBAC is not very commonly given, the repeat section rates are ever increasing. And unfortunately, because primary section rates are increasing, there is a general trend in the increase, section rates, increase in section rates. So it is rather unfortunate, but how do we bring down the section rates? Okay, for a community, the ideal rate of section beyond which there appears to be a null benefit, that is no benefit to either mother or fetus, is between 10 and 15%. Can you believe that? And we have reversed the ratio to the other way. Okay, next slide, please. So
basically,
what do we do? Why do we have to bring down the section rates? As I said, both mother and baby are at a disadvantage if the mother has section. Can you just elaborate on that, Srimati?
Sure. So basically, as ma'am was saying, the adverse outcomes for the mother and for the baby, both short-term and the long-term, are higher with C-section. As you can see here, this is from the American College. As you can see, with C-section, overall severe morbidity and mortality is higher compared to vaginal delivery. It comes to about all of them. You see 8.6, 9.2, 0.9, 2.7. All of them are substantially increased when women have a C-section. This is for the first section. If we then think about their next deliveries, increased chance of them having, subfertility, problems conceiving, and even if they conceive, they are 17% more likely to have a miscarriage if they become pregnant after a previous cesarean section. They're 27% more likely to have a stillbirth. I mean, these figures are really alarming. We do not counsel our parents with all these facts when they come for cesarean delivery with maternal request. I think it is important that we tell them what the evidence says. If they've had a previous C-section, look at the numbers. Having them have placental abruption goes up to 30%. Previa can go up to as much as 100%. Adherent presentation, more the number of C-sections, more the chances of have them adherent presentation. If they've had 3 sections, it can go as high as 50%.
Yeah.
And even if they are not going to have a repeat baby, they might say, I don't want another repeat. But you can see, this study has shown there can be dense adhesions in the repeat sections in 1 in 4. It may not be a repeat section. They may have to have a hysterectomy, or they may have to have a laparotomy for other reasons. So they're going to have dense adhesions, which will implicate their post-operative period and the operations.
I think that it doesn't make a difference. I mean, people are worried whether the obstetricians will be blamed for cerebral palsy or HIE if they gave a vaginal delivery. Can you show the figures, please? There doesn't appear to be. You want to?
So you see, this is from the NICE, and they have clearly said, if you look at hypoxic ischemic encephalopathy, CNS depression, seizures, all of them, there is no difference whether they're going to have a normal delivery or a C-section. So, in fact, if you see here, if they have a C-section, the chances of having a laceration, respiratory morbidity are going to be higher when they have a C-section compared to having a normal delivery. And the other concept is this one, ma'am, urinary incontinence, about, worry about future urinary.
That's right.
Here again, it is very clear. No difference.
That's right. So I don't think we should fear vaginal deliveries. That is a very, very important take-home message. Neither for the mother nor for the baby. Vaginal delivery is very, very advantageous to both. Okay, next slide, please. Talking about the long-term outcome of the babies. See, when the baby traverses through the birth canal, it is exposed to the vaginal microbiomes, and that helps in developing gut microbiomes. Gut microbiomes are responsible for 80% of an individual's immunity. So that gets programmed when the baby is passing through the birth canal. So it's so very important that we appreciate the nature's cleverness in making the progeny stronger by going through the birth canal. And as you can see, all the immunological related issues in the progeny is much less if they have had vaginal birth, including obesity. So inflammatory bowel disease, obesity, asthma, eczema, all these are reduced. So the quality of progeny is better, both short-term and long-term, with vaginal deliveries. Yeah, and I always used to wonder why the baby has to travel for hours together in the through the birth canal. I think this is one of the answers, that is, it gets programmed through and through labor. Okay, so thank you. And also indications for cesarean section. As you can see, there are many indications. We want to focus on two important aspects here. That is the labor arrest and non-assuring, reassuring fetal tracing. See, these both, if we can reduce the incidence of section due to these two, actually these contribute to 60% of your sections. So if, as Dr. Srimati already mentioned, using Zane's planogram can reduce the diagnosis of delayed first stage, delayed second stage, and also if we can have proper skill training in CTG interpretation, even this non-reassuring fetal tracing, etc., can come down considerably. And also, if we are well versed with intrauterine resuscitation of the fetus, the incidence can come down. Incidence of section due to non-reassuring fetal tracing. Okay, next slide.
Primary C-section, I mean, as ma'am said, almost more than 2/3 of the sections are because of these labor problems. And as we know that primary CS leads to repeat CS, it is important that we strive to avoid primary CS. So I think there are lots of determinants which make the lady have a C-section. How we manage them antenatally, what we do them in intrapartum care, whether we are inducing their labor, how are we managing their labor. All of these things play a major role in determining whether a lady is going to have C-section, and that is what we are going to be discussing as we go along in these case discussions. And the main reference for our case discussions for our presentation is this obstetric care consensus, which is a ACOG SMFM recommendation reaffirmed in 2016.
Yeah, I think it's important that we start bothering about reducing, optimizing the section rates right from the time that the lady books with you. Optimizing the gestational weight gain goes a long way in preventing gestational diabetes and also obesity related macrosomia, etc. So I think counseling, developing a proper mindset, I think amongst obstetricians and also amongst women to go through a vaginal delivery is very, very important. So prepare not only the mind, but the body also. And also exercises, antenatal exercises, yoga, etc. go a long way in preparing the body and mind for vaginal delivery.
So I think we'll just go to the first case. So I think more and more we are, at least in the cities, in the metros, we are seeing this problem coming up. So this was a lady who was a 32-year-old. She was a low-risk primary gravida. She was a software engineer. And she said, I mean, obviously it is not this corona time. It was before that. Anyway, because you might be wondering why, how can this happen in corona time? Anyway, so husband was working abroad. And so, he had to come in for delivery. And so she wanted to time her delivery. And she wanted a C-section at a particular day. We see more and more
than that, Srimati, more than that, the horoscope can be a real horoscope. So I think it's very important. Yeah, people want timed deliveries, even to the seconds.
So maybe,
are we
they
right?
use this to say, yeah, true.
Yeah, are we right? I think if we can counsel the couple regarding all the pros and cons of vaginal delivery and cesarean section, we have to see, and also give them leaflets, educative material. They can go through it repeatedly. I see whether they will change their minds, because it's very, very important for the obstetricians to change their minds and then the couple to change their minds. Okay.
That is true.
Yeah.
We have to be convinced first.
Yeah, I think so. And also, labor is a laborious process and obstetrics is full of tricks. I think as obstetricians, we should be friendly. Okay. And also we should be prepared to labor, to do good to women and the next generations to come.
That is right. So what we do is we give them detailed counseling in our unit to reduce this. We tell them all that we have discussed before in terms of the short-term, long-term outcomes to the mother and to the fetus, and we make sure 2 consultants concur with the decision. And if we feel that we are not happy to go ahead, we even think about refusing the treatment and referring them onwards. I think we should be bold enough to do that.
Yeah.
And this is a recommendation.
I think they can go through that because of the paucity of time. Shall we just move on to the cases, if that's okay with you, Srimati? Yeah.
Shall I start with the cases?
Yeah, please. Prakriti, can I request you to present the first case, please?
Yeah, ma'am. Okay, 30-year-old, gravida 4, para 1, living 1, previous normal delivery, had a low-risk pregnancy this time. She was found to have transverse lie at 38 weeks. Ultrasound had no predisposing factors for any malpresentation, and fetal growth was normal. We discussed options of ECV and also LSCS with the couple. They opted for external cephalic version. We did external cephalic version, which was successful, and we asked her to review in 2 days, where we found to have the presentation had reverted back to transverse lie again. And we rediscussed options again, whether we'll attempt ECV and attempt induction of labor simultaneously. They agreed upon it, and we did ECV, which was with ease. And as mother had pendulous abdomen, we used abdominal binder to wrap around her the tummy, which really helped in stabilizing the lie. And on examination, vaginal examination, it was a parasource 2 centimeter long soft central. We started induction firstly with PGE2 gel followed by misoprostol, and we checked presentations regularly, which remained cephalic.
Wonderful. Yeah.
And so once she progressed, we did her ARM, and later the progress was very quick. Within 2 hours, she was fully dilated, and she delivered a girl baby of weighing 3 kg with good upcast. Both mom and baby were well postnatally.
So this was a case of ECV. Okay. Yeah. You have another case for malpresentation, don't you?
Yeah, ma'am. I do have one. She's 26-year-old, gravida 3, para 1, living 1, abortion 1. Again, previous normal delivery, low risk pregnancy this time. She came to us at 37 weeks in spontaneous labor, and on examination there was a breech presentation, and she was already 4 centimeter dilated, well effaced, and breech was felt at -1 station. On scan, we confirmed which had an extended breech, and it was clinically average size baby. And we did a detailed counseling to couple regarding the benefits and risks associated with vaginal breech. And they agreed for the trial of breech delivery, and we took a consent for same. And labor progressed spontaneously, and within 4 hours she was fully dilated. We shifted her to theater with anesthetist as standby. And she had an uneventful assisted vaginal breech delivery of male baby weighing 2.5 kg with good upcast, and cord gases were normal. So in both the cases, we were able to achieve a successful normal delivery, avoiding these multiparous women having C-section. In the first case, successful ECV prevented her from having a C-section. And at around 30...
repeat ECV also, isn't it, Prakriti? A repeat ECV was done with the consensus. I think it is important. Yeah. If ECV has failed once, and if there are no contraindications, you review the indications, contraindications, and if there are no contraindications, there's no harm in retrying ECV. So that is how you have been able to achieve a vaginal delivery, which is very important for a second gravida who has had a previous normal delivery. Fair enough. Because the abdomen was very pendulous, I think you use the binder, which is very interesting. Lots of tricks in obstetrics, as I said. Yeah. And yes, just a veil you used, isn't it? Yeah.
Yeah, it was cotton dupattas. One tied at the cephalic end, at the lower end, and the one at the fundal end, and which did not hinder in the fetal monitoring.
Wonderful. Yeah. So to prevent, reduce the incidence of section in malpresentations, so you practice all these, do you?
Yeah, at around 36 weeks, when we find malpresentation like breech or transverse leg, other strategies like knee chest position and acupuncture, acupressure, these can be tried, but there's no strong evidence in it. If this doesn't help, then we offer them ECV from 36 weeks onwards. And the success rates of ECV being 50% in prime and multiparas, it's almost 60 to 75%.
Yes.
It's a good, rate. In case if the ECV is not helpful, suppose in the second case, if they came in spontaneous pains with a breech presenting in active phase of labor, if we had ruled out other contraindications, like it's not a footling presentation, or it's not a very large baby, it's average baby, if there are no contraindications, then definitely we can offer them vaginal breech delivery also, explaining the benefits and small risks associated with the breech delivery. And of course, at the time of delivery, we need to have a skilled or under the supervision of a skilled obstetrician. Delivery has to happen.
And you do it in theater, because there can be problems with the aftercoming head, etc. So I think it is important to have this and do it in theater. What about priming? If they come in labor, do you allow vaginal deliveries? Breech, vaginal delivery?
If in very advanced stage, suppose in second stage of labor, if they had come in second stage and clinically a small baby, we can definitely, there's no contraindication as such, but there are trials.
The term breech trial.
Yeah.
Anna, it's that a trial of vaginal breech delivery in primaries, even generally, they said it can have increased short-term neonatal outcomes. Minded, it was only increased short-term neonatal outcomes. Actually, the long-term outcomes evened out for both section and normal deliveries.
A lot of controversies regarding that trial, Srimati, to say the least. But if the lady is in labor, if she is progressing all right, even if she is priming, if the couple have been counseled regarding the risks, etc., I think you can still give a vaginal birth. Allow a vaginal birth. I think skills and drills are very, very important. So you have regular skills and drills session in your labor ward, and people will be more confident, and staff will know how to help you out and things like that. So I think it's very, very important to practice skills and drills, and ECV should be revoked. It should not be a forgotten art. Thank you very much, Prakriti. Yeah, thanks.
So now moving on. So these are various ways in which we can reduce C-section. What we saw was malpresentation. Of course, macrosomia, as we discussed earlier on, if you're able to give them a good antenatal care and if you're able to manage their diabetes better, we may be able to avoid section and saying macrosomia as an indication for that. Now, moving on, non-reassuring trace. This is going to be a very common problem in tracheotomy. How can we prevent sections or reduce sexual distress or suspected fetal distress as a cause for C-section? And I think I'll call upon Dr. Neelam to present a case, an interesting case.
Neelam is a consultant. Even Prakriti is a consultant in our team. And Prakriti is post-DNB with an experience of nearly 6 years post-DNB. And also if she is a fetal maternal specialists. Neelam is post MD, MS and MRCOG. She is a consultant in our team. They're all very enthusiastic, active practitioners of vaginal delivery.
So I'll be presenting a case of Mrs. S, who is 31-year-old primary gravida with history of ITP and stable platelet levels. She was GDM on OHA with normal growth and reasonable control. She was induced at 38 weeks in view of GDM on OHA. On vaginal examination, her Bishop score was found to be 3. So in view of her poor Bishop score, the decision was taken to induce her with propase, which was inserted at 9 p.m. and CTG after 1 hour was found to be normal. As you can see from this trace, the CTG is quite reassuring. She started having contractions 2 hours after the propase insertions. Contractions were found to be 6 in number, lasting for 40 seconds in 10 minutes. There was an episode of fetal bradycardia, which lasted for several minutes, followed by fetal tachycardia. At this point of time, vaginal examination was repeated. She was found to be 1 centimeter dilated with cervix 1.5 centimeter long, soft and posterior. In view of hyperstimulation, the propase was removed and injection terbutaline 250 micrograms subcutaneous was given.
So would you have sectioned her here? Because you see fetal tachycardia almost going up to 180 for nearly 20 minutes. So what do you do? Yeah.
So I wouldn't section her at this stage of time because fetal tachycardia was in response to the fetal bradycardia, which happened because of the hyperstimulation, which was taken care of by starting the intrauterine resuscitation and giving injection terbutaline. 1 hour later, her temperature was found to be 99.4 with pulse of 100. IV paracetamol and IV antibiotics were started after sending the bloods. With these measures, the CTG settled after 30 minutes. As you can see from this trace, initially the baseline was 180, 190. Now it is coming back to 160. Within 30 minutes, CTG was absolutely normal. That's why ARM was done 4 hours later when she was 4 centimeter. Liquor was clear and she progressed to full dilatation in 6 hours. And she had a van-to-assisted delivery for delay in the second stage. She delivered a live female baby weighing 2.4 kg with good upguards and cord gases.
So you have been able to avoid a C-section, So what do you think was the main, what was the main help? What helped?
So understanding the pathophysiology about the CTG, why the bradycardia happened and why there was a response to it in the form of fetal tachycardia, consulting the second on-call regarding the CTG, and simultaneously giving her injection terbutaline and starting the intrauterine resuscitation. Following and continuous monitoring. We did not leave the baby unattended. We monitored the baby continuously. Following all these measures, the CTG became normal and we continued the labor as expected.
So the reason for terbutaline was because she was hyperstimulating, and though you remove the propase and you would expect the contractions to settle down, because of the bradycardia, you would wanted the baby to recover quickly.
Yes. Yes.
So terbutaline acts pretty quickly, doesn't it?
Yes. So we were expecting the CTG to settle down within 20 minutes, and it did settle within 30 minutes.
So terbutaline 250 micrograms subcutaneously initially can start acting within 5 minutes, and you would expect a good response, almost 90% response within 15 minutes. And I think that is what you had in your case. Yes. And after which the CTG settled and she started contracting. So now you can just wait and carry on with the labor progress.
Yes, absolutely.
And one point is we shouldn't be doing an ARM at this point in time, though we are very tempted because we want to know what is happening with the baby. Because if you do an ARM, the contractions can increase, isn't it not? So you would have to wait for at least 30 minutes after the removal of the propase and wait for the contractions to slow down before we do ARM.
So that's why the ARM was deferred, because the CTG settled down.
That's right. So I think fresh pair of eyes plays a very important role, because we tend to be very worried because we keep looking at the CTG for hours and hours and we get fatigued, isn't it not?
And one important thing was when fetal bradycardia happened, we did inform the anesthetist about the scenario. because we wanted him to be on the standby in case we have to act on the CTG. So that was one important thing which we did.
That is right. So we need to have a standardized approach to interpretation of CTG, having regular CTG discussions, and having weekly or monthly review meetings of CTG, having a constant update goes a long way in the interpretation of CTG and reducing the section rates, isn't it not?
Yes, yes.
And of course, doing cord gases is very helpful because retrospectively, as we can see here, the cord gases were normal. So this goes to prove that the baby was not hypoxic, baby did not have any problems in the intrapartum. Baby had sufficient reserves and was able to cope well. So I think doing cord gases is very, very important whenever we have a suspected fetal distress baby with a CTG.
Yes.
Thank you, Neelam.
Thank you so much. Thank you so much.
I think the next case is going to be Dr. Sarita. So she has an interesting case, isn't she?
Yeah. Hello. Can you hear me?
Yes, Sarita, go on.
Yeah. I'm talking about a case who was 26 years old, primey. She was a GDM. Her pregnancy was, she had a medical disorders of gestational diabetes. She was controlled with OHA and insulin. She was called into the hospital at around 38 weeks for induction, as we usually induce for a woman with gestational diabetics at 38 weeks. Where at the time of admission, her Bishop score was 3, not favorable. So we started with Folis mechanical with oral misoprostol, 25 micrograms, 5 doses at an interval of 2 hours for 5 doses in a day. Still, her Bishop's was not favorable. The ongoing counseling was done with the couple, and they agreed to go for second method of induction. On the second day 2 of induction, we induced her, added on induction with Cerviprime gel of 0.5 milligram, and morning we continued with 5 doses of misoprostol. We updated the status of her labor, that is the induction stage of labor, to the couple, and the couple agreed to continue for induction if she is not favorable. On day 3, she had PROM. It was a clear liquor and she was about 2 centimeter dilated, and PROM protocol was followed according to her unit. She was augmented with syntocinon and labor progressed uneventfully, had a normal vaginal delivery at around 16 hours following PROM. Both mother and baby are fine. No events. Normal abgas and cord gases.
That is right. So we did very well in achieving a vaginal delivery in her, isn't
Yes.
it?
Yeah. Couple cooperated with us.
I think it's important that you counsel them, isn't it? I'm sure you prepare them in the antenatal period when they are being booked for induction, so that they are happy to wait.
Sure. Yeah.
And what do you think is the definition for induction? When should we have called it a day when she didn't actually respond with your first induction agent?
There is no standard specific definition which we follow for the failed induction, but if the woman doesn't achieve regular contractions, or if there are no cervical changes at least after 24 hours of any method, or following augmentation with artificial rupture of membranes if feasible, if she doesn't setting into labor in the form of contraction, establishing into the contractions, or there are no cervical changes, we call them as failed induction.
Yes, that's right. I think we need to give them a fair trial, isn't it not?
Yes.
One thought is, whether we should have, given her prostaglandin rather than Folis and Miso. I mean, it's difficult to argue, isn't it not? Because Folis and Miso also work very well.
That could have been an option, since we have seen few hyperstimulation with the propase, and also we didn't prefer propase as the first choice of induction, because if hyperstimulation happens, it will be in the odd hours where we need to call in anesthetist or immediate sections. So in this case, we preferred Folis with misoprostol.
I think it was because it was in the peak of the corona time, isn't it? Because the previous one, we had the same problem. She had propase, but hyperstimulation, it happened in the middle of the night, but we were able to manage. But because of the peak of corona, but otherwise, the Bishop score is unfavorable. We prefer to use propase as our first line of induction.
First line of agent. Okay.
Yeah. So I think these are few strategies which we would want to do, isn't it not? In order to reduce sections.
Yeah. Again, here we can reduce the cesarean section. What are the strategies we need to look into is, we need to review the indication again. But in our case, she was already 38 weeks. She was a gestational diabetes with OH and on insulin. She needed induction and proper agent, as you said. And if she's not responding to any of the methods, we need to review or call in our second on-call. And at the same time, maintain a counseling and inform the couple about the ongoing process. So what method doesn't work?
That is right.
Yeah.
Yeah, I think reviewing the indication is very important because if you're not desperate to deliver this lady, I think you should review the indication. That will also bring down the section rates. Of course, the couple have to be counseled and there has to be a consensus, etc. Yeah.
Yeah. So expectant management, if there were no indication, as ma'am was telling, or repeat the same method, same with prostaglandin, or repeat with a different prostaglandin. And last, give the option of cesarean section if she's not responding to any of the methods.
I think it depends upon individual scenarios as well, isn't it? On how she responds to the first, what is the bishop's change, and whether there are any other contraindications to usage of various medications. Based upon that, we can take a call what medication we are going to repeat, what induction agent we are going to use for the second time.
Yes.
And also, as a rule of thumb, in our unit, for any induction apart from post-its, we make sure that we discuss with two consultants agree for the induction, so that we can again bring down our rate of inductions, because more inductions and they disproportionately increase our CS rates. So that is also one policy which we follow, isn't it, not?
Yeah, that also reduces the cesarean section rates or induction policies.
That's right. Yeah.
So I think, thank you, Sarita.
Thank you, ma'am.
So moving on, I mean, this is also a very similar case. This is a 26-year-old. BMI was 38. I think more and more we are seeing this obese population, aren't we? So she was 40 weeks and 3 days, induced for post-its. Our AFI was 6.2. Bishop score was 5, but the head was at brim. Because we were slightly concerned with the AFI being on the lower side with a raised BMI, we felt monitoring might be a bit difficult, so she was induced with Foley's and misoprostol. But unfortunately, Bishop did not improve to a great extent, so we again counseled the couple like the previous one, and for the second day, we gave them Serpipran, but she got into labor, contraction started, and she progressed to 4 centimeters. So we then ARM'd her. She had a clear liquor, she had the full bugs, epidural was sighted, and then we examined her in 4 hours. She was only still 4 centimeters dilated. We did think about using oxytocin, but because she had very good contractions, we thought syntocinon is not needed, because if only the contractions are inadequate, we need to use oxytocin. So because she was contracting well, we wanted to give her some more time, because if you remember from the first talk, increased obesity, increased BMI increases the chance of delay in the progress. Also, induction increases the chance of delay in the progress. So that is why we wanted to wait. So 2 hours later, we re-examined her. She was 5 centimeters dilated, but because maternal parameters were fine, CTG was satisfactory, we again counseled the couple, and epidural was continued and CTG was continued. We did not need to use oxytocin because our contractions were still adequate. And actually 4 hours later, she did progress to 7 centimeters, which again, with the old criteria, we might think it is slow progress, but actually from the new criteria point of view, we are pretty happy with the progress. So we just counseled the couple and said there's a good chance she was going to get to full dilatation soon, and quickly, so she progressed in 2 hours to full dilatation, and she had a normal delivery of a male baby, 3.3 kilos, but normal gas and normal cord gases, and both the mother and the baby are doing, did very well in the postnatal period. So I think it is very, very important, especially in women with raised BMI, because both sections as well as normal delivery can be tricky. I think we need to strive to give them a normal delivery, because it increases their, the post-op, the post delivery recovery is much more quicker if they have a normal delivery. Chances of complications are far less.
And also the interventions should be kept to minimum. And also we have to keep them ambulant And cardless CTG monitoring would help enormously, especially in an obese woman, to get a proper tracing and also keep them ambulant. Yeah. So, yes. Yeah.
Yes,
So that is what Genitri is producing, the cardless CTG. Yeah.
Yeah. So one again point to emphasize, please do not routinely do amniotomy in centers, because it is just going to make them tight to their bed and, it's going to affect the progress and inevitably end up having a C-section. Especially if so in the latent phase, give them rest and analgesia if needed and wait and watch. And most of the times they do get into labor. So
Sure.
this is an
Yeah.
algorithm. So you do not diagnose active labor till they get 6 centimeters. Till 6 centimeters, be patient, wait, give supportive care. The minute they reach 6 centimeters, you can diagnose active labor, but still wait to see what is happening with their cervical changes. If there is no cervical change, think about rupturing the membranes, look at the progress. If they have good contractions and no progress, then after 4 hours, we call it a day. Whereas if the contractions are not adequate, we can even give them longer time.
I think we have to bring in a change in our mindset. As soon as they are 2 centimeters, 3 centimeters, we just rupture the membranes, put them on oxytocin, and just push them, rush them through labor. That will get us into more and more trouble. Okay, that's when a lot of CTG abnormalities can come up, and the lady can get restless, you can get restless, and invariably they can end up having a section, many times rather. So I think delaying amniotomy and also considering active second stage as 6 centimeters, from 6 centimeters is a very important thing if you really want to achieve more number of vaginal deliveries. Yeah. Next slide, please. Yeah.
Next, Bhargavi.
Yes. Here is the case who was a 30-year-old primary, low-risk pregnancy. She was admitted at 40+ weeks for post-base induction. The ultrasound scan, which was done at 40 weeks, showed normal growth and Doppler, an estimated fetal weight of around 3.43 kg. Bishop's score at the start of IOL was around 4. She was induced with 3 doses of oral meso, and she started having regular contractions with that and started dilating. She was 3 centimeter dilated with that. Coming to the labor course, ARN was done, clear like a drain, and epidural was given for pain relief. She progressed to full dilatation in 4 hours, vertex at -1 and an occipitotransverse position. No caput or molding was there. She was allowed for passive second stage for 2 hours, and the descent of the head was noted to 0 station with occipitotransverse turning to occipito-anterior. Minimal caput was there was no molding. Commenced pushing and reassessment was done after 1 hour of pushing, and descent of head was noted to +1. CTG started showing recurrent variable lesions, hence decision was taken for trial in theatre. A written consent was taken from both the patient and the husband in view of trial in OT bar cesarean section, and we shifted her to OT, and anesthetist was called in. Reassessment in the theatre showed CTG no deterioration. Parabdominal 0 fifth palpable, and V was fully dilated, rotated to occipito-anterior, and +1 below spine, and minimal caput. Nebelbarn's forceps was applied, easy application, and 2 pulls. Head retraction and signs of shoulder dystocia were noted after the delivery of the head. Delivered by macrobus and suprapubic pressure. A female baby weighing 3.98 kg with good upcast and with good cord gases. Incident form submitted, and debriefing was done to the parents, and documentation of shoulder dystocia was done. Both baby and mom did well postnatally.
Would you say that you achieved a vaginal delivery because you took her to theatre, Bhargavi? And also, if so, when would you take them to theatre?
I wouldn't say we could achieve a vaginal delivery only because we took her to the theatre. We achieved a vaginal delivery, I would say, is because we waited according to the protocol in the second stage of labor without overreacting. And
yes, great.
we took her to the OT in view of CTG abnormality. And also because there was a delay in the second stage of labor, we took her to OT so that if any case there is any necessity, we could just take her for the cesarean section so that everything is ready beforehand.
Yeah, I think it's very important to make sure that nothing is I mean, in the sense, cephalic is 0/5 palpable, and also, yeah, to reconfirm the position before we applied the instrument, isn't it? Didn't you think that, yeah, gave you more confidence? Yeah. And also, being in theater gives you much more confidence because she's had a prolonged second stage. And in case you had to section, or in case you had to manage shoulder dystocia, or even, I mean, PPH is not an unknown thing. So I think having an anesthetist will be a great help. And it definitely gives us a lot of confidence to deliver women vaginally. Yeah, I mean, when would you consider such trials in theater, Bhargavi?
When we are expecting a clinically bigger baby whom we are expecting shoulder dystocia with the risk factors which are being present, and also like this prolonged second stage of labor, or when they are fully dilated and there are some CTG issues also, we will be shifting them to the theater, because in case the CTG deteriorates by then and we are not able to achieve a vaginal delivery, we might take a decision for a cesarean section in case we have not given enough time in the second stage when she's just fully dilated or anything like that.
Mm-hmm.
And also when there is occipito-posterior position, we would be comfortable delivering them in the theater because the failure of instrumentation is, the chances are high. And also, of course, when perabdomen is around 1/5 palpable, it would be better to shift them to the OT and probably examine her again in asking a senior obstetrician to come in, and then reassess if we are not confident enough that we will be able to handle the situation alone on our own.
Yes, I think if it's after analgesia, I mean adequate analgesia or even anesthesia, assessment in theater would be very important, both perabdomen and also vaginal. So that will give you a good idea whether this baby is going to come out vaginally or not, isn't it? That's what we did even in this case, isn't it? Yeah. Thank you.
Appropriate usage of instrument, selection of instrument, being very proficient both in rotating forceps as well as ventus, and choosing though individual cases, I mean though individual operator preference is what we recommend. I think it is important to select the appropriate instrument so that we can avoid failures and avoid sequentials.
True. And also practicing skills and drills. I think there is no replacement for practicing skills and drills. Yeah, I think every one of us should be polishing our hands with skills and drills. Yeah, and skills in instrumental delivery, drills in instrumental delivery, drills in shoulder dystocia, drills in PPH, everything goes a long way in managing obstetric emergencies. Yeah. Shall we go to the next case, please? Yeah.
It's probably the last one. I think we are running short of time.
Yeah.
So we can
Lady,
finish with this.
32 years old lady, primary gravida with gestational hypertension. She was planned for induction labor at 38 weeks, and her Bishop score was less than 4 at the induction of labor. So we Propus was a suitable agent for induction of labor. It was inserted vaginally, and at 18 to 22 hours, she had spontaneous rupture of membrane and she picked up pains. So on examination, she was 2 centimeters dilated. So since she was in picked up pains and she was in regular contractions, we took a decision to remove the Propus, and she went down at 4 hours of labor. When we assessed her, she was 5 centimeters. Then following which, we were called in at 3 hours, 3 hours later for fetal bradycardia, and we
did all intrauterine resuscitation by giving IV fluids, and a quick examination was done to assess what is the cause for sudden bradycardia, to look for vaginal examination for the cord prolapse, or if there is any excessive bleeding. Clinically, she was fully dilated, and the position was OT, occipital transfer, and station at 0 station. And per abdomen, cephalic was 0 for palpable. At this stage, the fetal bradycardia continued even at 6 minutes. So we took a decision to abolish the uterine contraction by giving injections terbutaline 250 micrograms subcutaneous. And also we alerted the OT, anesthetist, and the pediatrician, and shifted her to OT in anticipation of difficult delivery, and she may need section also. So in theater, when we re-examined her, FHS are already picked up, and on vaginal examination, vertex was 0 to +1, and position being OT to OA. Since the FHS was picked up, we encouraged her to push bear down, but however, CTG again deteriorated. So we did a manual rotation from OT to OA and conducted a ventrose delivery. And with 2 pulls, delivered a female baby around 2.6 kg with good upgas and normal gases, cord gases. So it's very important here. Yeah.
I think it's very important to recognize that bradycardia can recover on its own, isn't it?
Yeah. 90% of them without any pathology, by 6 minutes they do recover with our intrauterine resuscitation, and by 9 minutes, 95% of them recover. In our case, the fetal heart rate has recovered because of our intrauterine resuscitation.
And I think it's very important to continue intrauterine resuscitation. Yeah, even if when you are taking a lady for fetal distress, if it's not recovering, terbutaline should be given before we shift her to theater, so that the baby is not very distressed with further contractions, isn't it? That's what you did here?
Yeah, we give the terbutaline before shifting her to theater. So that by shifting theater, at least we take 5 to 10 minutes. So terbutaline did help to abolish the contractions, and fetal heart rate picks up.
Yeah. And once the heart rate had recovered, you gave her time, isn't it? Which is
we gave her time because because prior to this, bradycardia CTG was absolutely normal. So we did give her time because FHS had recovered. And since again there was a repeat deceleration, we took a decision for instrumental delivery.
Yeah, obviously when there is a bradycardia, you rightly examined her to make sure that there was no cord prolapse or there was no signs of abruption. It was only hyperstimulation, you thought, probably?
Yeah, that's the reason. That's the reason we gave her terbutaline. Maybe because of hyperstimulation.
Yeah. Okay. Wonderful. Yeah. So I think there are various ways to reduce the sections. You should be geared up for it. You should think what exactly is the problem with the baby and what's happening, but can we revert it? So intrauterine resuscitation goes a long way. Yeah. Hello? Thanks, Vinita. Hello?
Yeah, thank you, ma'am.
Yes, ma'am.
Thank you.
So I think it's important
Vinita
that
is one of the senior consultants, very bold in her obstetric practice, very sort of glad to have her with us, and she is a fertility specialist also. Thank you very much, Vinita. I think Dr. Sarita and Dr. Bhargavi probably, were they introduced, Srimati? I know there is paucity of time, but...
they presented, ma'am,
sorry?
They presented, we didn't introduce, we just told their names.
Yeah, Dr. Sarita again is a post-MRCVT. She was a consultant in Chennai and now with us, again, very keen obstetrician and interested in menopause. Bhargavi, post MBBS, she joined with us, did her MRCOG, and she is also a very keen obstetrician. So we have a gang of teen obstetricians, if I may say. But I think it is very, very important to practice in a group. That can really reduce the section rates, and also there will be help available immediately. And also you are not exhausted because you are taking on-call on rotation and things like that. So I think that should be the way forward if we really had to do a lot of good to our women and have quality progeny. Next, please.
We will have to finish, I think, because we are running, right? So maybe we can summarize and finish off, because we had one more case which we wanted to present was twins. Just one word. We can produce CS in twins. We can give them the option of a vaginal delivery, especially if the first twin is cephalic. Of course, counseling and having an experienced, trained personnel is very, very important if you have to deliver twins vaginally. Having anesthetist, OT and NICU on standby is very important, but it is achievable in twins.
Yeah. I think it's very important to categorize the sections. The indications have to fit into one of the categories, the Robson's criteria. I think we should have a proforma, printed proforma for us to fill in the section details. And this picture, I think we should have it, this chart, we should have it on the section documentation sheet. Don't you agree with that, Srimati?
Yes, ma'am. We do use Robson's for classifying all of the sections, and it helps us to reduce or at least concentrate where our sections are happening, so that we can put an appropriate strategies in place to reduce our primary sections.
Yeah, helps enormously in auditing, introspecting, and see how we can improve. Yeah, okay. I think we need to change our attitudes as obstetricians and also couples' attitude towards normal delivery. Too posh to push has become too common. I think they need to change, and also as obstetricians, we should be prepared to labor, yeah, with the labor and give the best to the woman. Yeah. Group practice is another important thing. We should be adequately supported by our colleagues, especially the anesthetic team and also the NICU team. Counseling goes a long way. Also educating to-be parents regarding the benefits of vaginal delivery is a very, very important strategy in reducing section rates. Yeah.
So, thank you, ma'am. So
thank you very much, Srimati, and all our consultants who have contributed to this case discussions. And I mean, all those cases were handled by them. And thank you. Congratulations for achieving vaginal delivery again. Yeah. Thank you.
Thank you for this wonderful case discussion, the whole team. And I think I can see that it's really helpful when we actually discuss the real case, and it's really helpful for the audience as well. So let's move on to the next session by Dr. Srilakshmi, which she will be talking about the performers and protocols in obstetric emergencies. So Dr. Srilakshmi, it's all on you. If you can share the presentation and take it forward.
Thank you, Mr. Arun, and for giving this opportunity to talk on the protocols and performers in obstetric emergencies. So till now, we saw how do we practice. So every now and then one of the speakers was telling about using the protocols. So I'll be talking about how to use the protocols in obstetric emergencies where speed is very important. What is an obstetric emergency? Emergency, we know it is any serious or a dangerous situation which can come up suddenly and unexpectedly, and it demands an immediate attention and action in order to save life. Okay, so obstetric emergencies are health problems that are life-threatening for both mother and the baby. So we are dealing with two lives here. Okay, so this obstetric emergency may arise at any time during the pregnancy, labor, and birth. So what happens usually, all the obstetricians are aware of it, whenever there's an emergency alarm goes in the labor room. So every nurse or every consultant who are able to hear those bells will rush to the labor room. They want to help the woman. They want to deal with the emergency. They want to help in every other way. The questions fly. The task will be completed and everything will be fine, resolved. But should we go through this chaos every now and then? Can we handle it in a better way? Definitely we can handle it in a better way. It has been studied that whenever there is obstetric complications are there, and it is always compared these obstetric emergency to scenario like any abnormality during an automobile accident, where people rush in, they want to help. They want to help the person who is went through the accident. They want to help each and every person in that scenario, but there should be a task which has to be fulfilled. Okay, so what happens when everyone rushes in? It has been studied that important steps can be missed in an emergency situation. Okay, so developing a clear plan for as a response for the common emergencies can ensure that the tasks are not redundant or omitted, and we can create an environment which is very positive and promotes the positive outcome. So for this, we need to have, so it has been seen that all decks on hand, all hands on the deck will not help, because we need to have people, but people need to understand what to do. So for that reason, we need to have a protocol to prevent or minimize errors during the obstetric crisis. So protocol is a way forward. So what do you mean by a protocol? Protocol is a set of standardized interventions which are performed to manage a given situation efficiently. Okay, so we can tell that protocol can be a code of practice which can be used synonymously with the clinical protocols. That means we need to follow certain steps at that time period to have a positive outcome. So how do we develop protocols? It is developed based on the available evidence-based guidelines, the exact nature of the protocol. So how do we take this evidence-based guidelines through various college like RCOG, ACOG, and SMFM, all those things. And when we take the guidelines, it is for their population. But when we follow protocol, when we frame a protocol, it should be depending upon our work environment and what are the resources we have in our working environment. Okay, and whenever we frame a protocol, it should be clear, it should be concise, it should be as short as possible, because if you have a lengthy protocol, the people may not be interested to read it for a long period of time, and especially in an emergency, it should be short and swift, and it should be clear, and the clarity should be fine. So these are all the beneficial characteristics of the protocol. So how the protocol helps? When the speed is important. Okay, so the coordination that a protocol provides in a speed is very important. I can give an example that every obstetrician knows. Whenever the woman has a cardiac arrest, we need to do a emergency postpartum C-section within 4 minutes. So whenever there's a shoulder dystocia, we need to deliver this baby within a minute. Okay, so when we see that any turtle sign in the protocol, we'll put, if you see a turtle sign, this is a movement to call for the help and do following maneuvers. So whenever the speed is important, the protocol plays a big role in this. Okay, so coming to how the protocol is important, the ACOG has come out with a committee opinion that there are certain tools to manage the clinical emergencies, and they have told that having a protocol, including the protocols to follow to bring up the clinical triggers, is very important in managing the clinical emergencies. My first protocol will be a protocol for a clinical trigger, which we call it as NEOS. Okay, it is a simple physiological scoring system for a bedside application. It identifies the patients at the risk of deterioration and urgent need for active intervention. So it can be applied if you want to have it in your management. You can apply near to in the labor room, or in the postpartum period, or in the antepartum period. Any time where you feel that the mother needs a continuous care, you can apply this protocol and see. So it is called as a modified early warning scoring system, or a MUSE. Okay, so what does it do? It recognizes the problems. It will help in referring the problems to the appropriate personnel, and also it will help in the management of this problem. That is, the personnel who comes to review the woman will look through the investigations and he follows with the management. So we are giving an appropriate management for the woman whenever we put them onto the protocol of NEOS. And who will be doing this? The staff nurse will be taking care of the woman, will be doing this. So what does it contain? It contains certain parameters, as you can see here: the respiratory rate, the oxygen saturation, the temperature, the heart rate, and the blood pressures. So, and you can see the date and time here, and we have put some parameters here, and each parameter has a mark as a red or a yellow or a white. So if the trigger is for red, then it's a serious condition. It's a trigger for yellow, probably that is also to be informed. What will happen? The doctor should be contacted for the early intervention if the patient triggers 1 red or 2 amber scores at any one time. Okay, so each unit can have its own protocol regarding the trigger. If there are many people, if the availability of the anesthetist or the ICU is very much handy, then we can put a trigger for a later on. But if the people need to be collected and they have to be called from the different places, probably a trigger at a lower trigger point itself can save the lives. So what are the triggers here? If you take an example, if the systolic blood pressure, we take it as a parameter. The red trigger, if it is less than 90 or if it is more than 160, but if it is a yellow trigger, is 150 to 140. But you feel the members who need to manage the emergencies are staying far away, we can reduce this trigger to 140 to 90 itself. So that itself will be a trigger to call in people to manage if there are not much facilities in your department. So the diastolic blood pressure is more than 100 is a trigger, 90 to 100 is an yellow trigger. And if you take an oxygen saturation also, it is less than 95, you call it as a trigger to call up the doctor and see the woman and manage the condition. So the higher the score, the sicker the patient, so the earlier you need to act. Okay, women with 1 yellow score or red scores must not be transferred if some staff nurse is managing the patient and she puts a trigger as yellow or red. She should not shift the patient either of the theater or the delivery suite until a senior medical review has been taken place and a management plan has been decided and documented. Okay, so then and there only the patient has to be shifted out of the current scenario. So this is how, by having a modified early warning score system at every, what we do in our hospital is we put this Mio scoring, that whenever there is a patient with a higher blood pressure or anybody had a PPH or anybody had a fever in antenatal period, we ask our staff nurse to follow the Mio's chart and ask her to tell us whenever there is one red trigger or yellow trigger, so that we can monitor them frequently and we can manage the task efficiently. Coming to the other protocols, what we have formed in our hospital is we have formed a protocols for emergencies. We know a lot of obstetrician knows what are the emergencies, and we have placed those emergency protocols in a laminated book. We keep it in the labor room. We keep it. We have a separate protocols for the OPD, for the ward, and for the triage area also. So, looking at some of the examples of the cord protocols, I have placed in a protocol for the cord prolapse. So, what are the things we need to see when we glance at this sheet for once? We know whom to call. We know it is an emergency and we know whom to call here. And what is the next step? Next step is whether the fetus is alive. What is is it a viable gestation? If it is a viable gestation, is the cervix fully dilated? Is the baby alive or not? So once we know the series of steps at a glance, we know to act very swiftly. Okay. Then if we know it is a cephalic presentation and we want to deliver them, we want to reduce the pressure on the head, on the cord by the head presenting part. So how do we displace the presenting part? So these are all the things what a protocol provides you at a glance. Okay, once you see it, we know what to do. So another example of the protocol is the eclampsia. Again, a serious, it's an emergency where we call for help. We place the woman in the left lateral position. So any staff who rush in whenever she hears a bell that there is a need for help, she knows what to do to the woman and whom all to call and what is the medication to be given. So what is the importance of this protocol is everything is at a glance, and the speed is the one which matters in emergency, and definitely these protocols will help in giving that speed and also saving their lives. Again, a PPH, more commonly we see as an obstetrician. So whenever we have a major PPH, this is how we manage them. Okay, call for help again. Simultaneously, we should be resuscitating, we should be treating, we should be sending for investigations. So all the things has to happen immediately, and one person cannot be managing this. So what they do, they'll call for a senior staff, obstetrician, anesthetist. So everything is inside one page. Okay, this is what the protocol gives an advantage for you. Okay. Not only as a protocol in a laminated paper, you can place it as a chart also. Okay, we have a chart of eclampsia which has been placed in our labor room, and we have a chart how to manage the sepsis in our triage area, because anybody comes with a diagnosis of sepsis, we make a diagnosis of sepsis in the triage area. These are the things which has to be managed within 1 hour. So, and we have a chart even for anaphylaxis, cord prolapse, all those things. So definitely shoulder dystocia, whom to call and what are the manuals has to be done. So all these things as a protocol definitely helps. But you should be remembering just placing the protocols or just placing a chart in your labor room doesn't help you. Okay. So if you're seeing at the protocols for the first time, as the emergency prevails, nobody can act. So what Dr. Lata has emphasized, regular mock drills. Okay, skills and drills has to be practiced every now and then, and having a talk with our staff or having a discussion or a lecturers should be a part of our practice, okay, to follow these protocols. Just placing the protocols and not telling anybody is not of issue. So we should tell. What we do in our department is, whenever a new staff or a new doctor gets introduced to our department, in the induction program itself, we ask them to go through the protocols. We ask them to go through the protocol books which have been placed in the various areas. So always remember to regularly practice the skills and drills and follow the protocols before the emergency arises. Then only we can act swiftly during the emergencies. This is regarding the protocols. Now, what is pro forma? So whenever an emergency happens, all of us will know through the protocol what to be done. But something has to be documented during the emergencies, because when we don't know how to know where we are going, we should know how we have been to that level. Because how do we know where we are going if we don't know where we have been to? So in order to improve our skills, or in order to improve the safety during the emergencies, that what we have done during the emergencies has to be documented. So documentation cannot be happening in emergencies in lengthy way. So if we have a pre-printed forms in emergency, the documentation can happen. So this is called pro forma. It is a documentation of the event and the actions on the pre-printed forms in an emergency. Okay, why we need to document? Because we know there's a medical legal issue. If not documented, it's not done. Not only that, when we document the things on the pro forma, it is easy because it is a pre-printed form. It is a formatted one, so it is a tick box will be there. So you can just put a tick, and it will save our time. Not only that, it is a backend data to do our research, to do our audits for the clinical governance and publications too. So it's pro forma as a standardized documentation. So as I told you, documentation also reflects the quality of care. Okay, it has shown to improve the documentation. The pro formas have been shown to improve the documentation standards in obstetric emergencies. Pro formas have shown to be beneficial as it is more standardized, clearer, and more concise. Okay. This is an example of a shoulder dystocia documentation. We know we have called in, we have put in emergency buzzer, everybody came, we did the maneuvers, everything done. But somebody need to document it. What we document, name of the patient and who are all present during the delivery, what time they arrived. And most important here, if you can see, this is a protocol which pro forma which has been taken from the ASIOG guideline. So what is this, which hand was, shoulder was anterior during shoulder dystocia. So here clearly putting a tick box here clearly tells us which shoulder was anterior, because the anterior shoulder is the one which is more often involved in palsies. So we know clearly, we have documented during the medical legal issues also, if somebody unfortunately lands up having a Erb's palsy, this documentation definitely helps us in giving an upper hand in clearing that medical illegal issues. So similarly, there's a documentation for cord prolapse also. Okay, another important thing I wanted to share here is the WHO surgical safety checklist, which is a pro forma pre-printed. So it will tell us what are the things you need to see before induction of anesthesia, before putting a skin incision, and after all the procedure being done, before the woman leaves. What are the things you need to look for the safety of both the patient and the obstetrician, and for the medical legal purposes too. So whenever there's an emergency, be prepared. Have protocols with you, have pro formas with you, and be safe to yourself. And especially, you should be very safe to both the lives which you deal as an obstetrician, for both mother and the baby. Thank you so much.
Thank you, Dr. Sri Lakshmi. Thanks for, I think protocols and pro formas are really important to actually make sure that quality and effectiveness.
Thank you.
Yeah. So if you can just close your presentation. So next is Dr. Lata, who will be actually talking about how to keep our labor wards safe.
Yes. Yeah. I think if you have to achieve vaginal deliveries, you really have to keep your labor wards really safe. I request Dr. Srimati to project the slides, if you didn't mind. I've had terrible problems with the network for whatever reason. Sorry about that. Okay, so how to make our labor wards safe? Next slide, please. Yeah. So labor ward is a unique place. It's a place of arrival of a new human life. Everyone seeks a bundle of joy and a safe mother. Nothing less than that is acceptable by anybody. Yeah, including the doctors and the family. It's a place of extreme peaks of pleasure, pain, chaos. Excuse me, sorry, Sri Lakshmi, can you mute? Yeah, yeah. It's a place of extreme pleasure, pain, chaos, confusion. Anything can happen. Actually, each and every patient is an emergency in the labor room. I wouldn't say patient, but a parturient. So there are two persons to look after. One is the mother, who is a manifest, she is visible to you, but other patient is really hidden. Both are traveling the most difficult journey of their lives, but everyone expects, as I said, 100% perfect results. So it is a challenge for us. That's why many obstetricians nowadays feel, oh, it is not worth taking that effort. It is not worth taking that time. And it is better in 20-30 minutes, we get the baby and mother safely out of the theater. But that is not so. That is what we want to emphasize. This train runs every moment of time, peculiar to choose the oddest day and hour. Yeah, 2:30 in the morning is typical admission, isn't it? Okay. Labor room, again, it's a unique place because, I mean, if you want to be a skilled obstetrician, you need a safe labor ward. Knowledge, skill, experience of the obstetrician requires a well-located, well-equipped, well-illuminated, clean labor ward supported by proper staff and also supported by proper multidisciplinary colleagues. It's duty as well as right for our mothers and also ourselves to keep our labor ward safe. Next slide, please. So the key points, actually, location and layout is very important. Personnel important, furniture, equipment, instrument, risk management issue, documentation as elaborately being dealt with by Dr. Sri Lakshmi. All these are very, very important. So location and layout. See, it should be well signposted. Labor ward, you should not be going in search of a labor ward. Anybody should be able to sort of step into, I mean, the laboring woman should be able to step into the labor ward in a designated maternity service area. It should not be changing every day of the week. Okay. And also there should be a central nursing area where the lady is received and treated with dignity. There should be adjoining NICU, adjoining theater, adjoining recovery room, triage, and large double doors for easy transit of large trolleys, personnel, because we don't know what sort of emergencies we are going to get in the labor ward, and also changing rooms, and also easy availability of changes and things like that. Next slide, please. So triage area is a very, very important area. Of course, we will talk about HDU, scrub area, wash area, etc. Triage area, I would like to talk a bit more. Next slide, please. It is an area where you decide what to do with this woman. Okay, so triaging, what is the risk? What is it that we want to do with this lady? Do we want to send her home? Do we want to admit her to the ward, labor ward, or directly push her to theater? Or is there a life-threatening emergency? All these are assessed in triage area. Next slide, please. Because, next slide, please. See, this is OTAS, obstetric triage acuity scale. It's very, very important to hang these charts in our labor triage areas, because the prioritization has to take place if we have to save lives and also keep the labor ward safe. I think it's so very important to have these charts. It is available on the net, and also it is available from various colleges or even various standardized hospitals. So please use OTAS to triage your women. Next slide, please. So HDU is another area where you want to observe the high-risk women who need close observation, where you have to use your Muse chart, etc., focus for intensive monitoring, because there might be a threat to the life of the lady or the baby or both. Next slide, please. So HDU should be adjacent to your labor ward, or it should be within the labor ward. And HDU care, Muse is very, very important, as Dr. Sri Lakshmi has already emphasized. So labor room complex should have a good wash area, because labor room is one of the most I wouldn't say dirtiest, but messy and bloody area. So you have to use the color-coded disposable bins, which are very, very important. And washroom area should be in close connection with the labor ward to make rapid cleaning possible. And also safety of staff while washing, etc., etc. Using protection is also very, very important. Taps, and also uninterrupted water supply. All these are very important if we are talking about wash area of the labor ward. And labor room equipments, I think they should be available for rapid sterilization, because you don't know which lady is going to come at which time of the day and how many labors you are going to have per day. All these are unpredictable, and also especially forceps, ventouse, etc., may not be available in large numbers. So you should be able to sterilize them at a short interval. So labor room equipments are very, very important, because furniture is very important. Next slide, please. The labor cot is very important. Next slide, please, Srimati. Yeah. So labor room equipments, labor table, it need not be necessarily a very costly, posh looking this thing. We are not coming to, I mean, labor room are not hotel rooms, mind you. And all, but safety is the utmost important thing. So it should be of good size, it should be comfortable, and also quick and smooth change of position, preferably hydraulic if one can afford it, or at least we should be able to give a Trendelenburg or head up position easily. Side support railing is very, very important, and also lithotomy stirrups are very important. You should be able to support the women's knees and also ankles. And also important to have built-in IV drip stand, and also buckets which can be fixed to the labor table. Labor room lights, again, are very, very important. We should not be having labor room lights like as if they are bigger torches and things like that. See, it's very important to have a proper illumination, because PPH tears, all these, if they have to be dealt with on an emergency basis, you really need very good lights. If you really want to prevent, PPH, labor ward, prevent blood loss, excess blood loss, I think labor room lights are very, very important. Good shadowless lights are very important, and one focusing stand light, preferably shadowless, should be kept as a standby. UPS connection should be there for continuity and safety, and also inverter backup for few lights is a must. Good number of tube lights on the walls is also a must, okay, to observe the lady. And also, it's just not the perineum, but you have to look at the lady in good lights. So another thing, life support for mother. You cannot compromise on life support equipments for the mother. Wall mounted central oxygen and suction, but with a backup of oxygen cylinder is very important. And also a backup suction, which is not wall mounted, it should be a suction trolley should also be available. So these two are very, very important for a laboring woman, and if you really have to save lives in emergency situations. Cardiac monitor or at least pulse oximeter should be there. Crash cart for emergency drugs, fluids, and also defibrillator should be available, because you can have emergency especially maternal collapse, cardiac arrests and things like that can happen. So it is very important to have a defib. And also, next slide, previous slide, please. Previous slide, please. Yeah, okay, next slide, please. Sorry. Yeah. Basic equipment, you should not be forgetting about your stethoscope, BP apparatus, fetal Doppler, cardiotocography machine, and also to compensate in case there is a shutdown for whatever reason, heavy duty torch. And also calling bell is very important, especially if there is only one staff looking after, or if there is no staff in the labor ward, the lady should be able to sort of press the bell and ask for help. So very important to have a calling bell in the vicinity, which is reachable by the lady. Instrumental delivery trolley should also be available. Patient shifting trolley, wheelchair, all these should be available in the labor ward area. Next slide, please. Next slide. Yeah, syringe infusion pumps. We should be using syringe infusion pump, especially for epidural infusions and also oxytocin infusion. Even a small dosimeter can act as an infusion regulator, especially for oxytocin. You don't have to have very costly equipments, but wherever there is a possibility, I think you should use epidural infusion pumps and also oxytocin infusion pumps. Next slide, please. Yeah, cardiac monitor. Very important to have a cardiac monitor, especially in HDU area, or at least a pulse oximeter. It should be kept handy, I would say, in every labor ward to make the labor ward safe. Next slide, please. Yeah. Crash trolley. We have to have a crash trolley, and oxygen cylinder should be fitted to the crash trolley. PPH and emergency obstetric kit should be available. Emergency obstetric drugs should be available. Portable defibrillator, and not only emergency obstetric drugs, but emergency drugs like adrenaline and antihistamines, etc., should be available. Noradrenaline, etc., should be available. That all comes in the crash trolley, and it should be checked on a regular basis. And portable defibrillator must be placed on the crash trolley, and there should be a checklist. And with every change of shift, this checklist should be checked and ticked. There's no point just this checklist hanging on the trolley. Okay. Anesthetic equipment is very, very important, because in an arrest situation, it is very, very important. And also, I mean, even not only in the obstetric theater, but I think there should be one more anesthetic trolley which should be available. And if it is a can't prolapse, retained placenta, etc., we should be able to sort of manage in the labor room itself. Next slide, please. Fetal monitoring. So that is about the maternal safety. What about the fetal safety? We should have at least the Doppler and also the CTG machine to monitor the fetus to make sure that it is well. Next slide, please. Yeah, so we have a remote fetal monitoring. This is the Genethri's Care, which is a cardless fetal monitoring. The fetus can be monitored remotely, and also centralized monitoring is possible with this device. I think it's a very, very important advancement in fetal, cost-effective advancement in fetal monitoring, fetal-maternal monitoring in our country. Next slide, please. Yeah. So the graphs are comparable to the traditional CTG, at least 80 to 85%. Next slide, please. Yeah. What about after the baby is born? I think you should have the neonatal resuscitator ready. It should be switched on just before delivery, well before delivery, I would say, and warmer should be made, should be checked, and all these equipment should be checked, and there should be pre-warmed towels, and neonatal resuscitation trolleys should be checked before delivery. Yeah, even the labor ward as such, with every shift handover or change, it should be checked, especially whatever I told you for maternal safety, those equipments should be checked. Next slide, please. So pediatric stethoscope should be available, oxygen supply should be available, and also suction should be available separately for the baby. Okay, we should not be pulling the mother's section, mother's oxygen to the baby and sort of to and fro. It shouldn't be done, really. It should be available as a separate thing. And neonatal, crash trolley for resuscitation, pediatric ambu bag, face mask, etc. should also be pediatric laryngoscope. All these should be checked prior to delivery. Next slide, please. Yeah. So all these should be placed, on a trolley so that it's easily available. So we should not be wasting time in emergencies. So very important to make sure that these are checked and placed in proper positions on the trolley. Next slide, please. Next slide, please. Thank you. Yeah, and there should be a neonatal staff who would attend to or receive the baby and also help the pediatrician. So personnel, designated labor ward staff who are trained in skill centers, midwives, auxiliary staff, technical support, all these people, midwives, auxiliary staff, they also should be trained in skill centers, including your ayahs should be trained in skill centers, which is very important. So because the number of hands that you get may be limited, and every hand, every minute saves the woman. Okay. Uniforms and ID badges are a must, because nobody should be walking around roaming around the labor ward area. And also, you know, medical legally, it's very important that we maintain the safety for the babies to make sure that they are not lost from the labor ward. Bleeps and mobiles should be available at all times, and their telephones should be working, and all the labor wards should be well connected. Designated labor ward staff, the nurse to patient ratio, 1:2 patients in labor, and in second stage of labor, it should be 1:1. Patient with medical or obstetric complications, or if it is a high-risk labor, I think it should be 1:1. And initiation of epidural analgesia, you need closer monitoring, it should be 1:1. So the ideal patient to nurse ratio in labor ward is 1:1. But of course, if it is a busy labor ward and if you are looking after more of low-risk labors, it can be 1:2. Next slide, please. Not more than that, ideally. Next slide, please. So storage space and cabinets should be convenient, easily accessible, well labeled, so that anybody and everybody can pick it up and bring it in times of emergencies. Any equipment, anything should be very well labeled, and it should be in transparent cupboards. Next slide, please. Delivery sets, instrumental delivery equipment, catheterization set, ARM set, epidural set, emergency obstetric kit, PPH drug box, PPH tray. All these are important things in the labor ward. As you can see, it has been, next slide, please. As you can see, these are all sort of kept where, yeah, it can be easily sort of picked up by anybody. For example, if it is a delivery tray, yeah, a delivery tray, it is bundled and kept ready. So if the lady comes in with full dilatation, you're ready to sort of deliver her. You just open this kit and everything is there. So it saves hands, saves time, saves the woman's life, makes it safe. And epidural tray, yeah, catheterization tray, ARM tray, all these. Delivery set, for example, all the contents of the set are labeled. And previous slide, please. Yeah, previous slide. So, yeah, it should be labeled and it should be ticked that it has been placed. And also whoever has packed, they should sign, and also whichever is the date of autoclave should be well visible on the with the litmus paper on the delivery set. So next slide, please. Yeah. So delivery set, it should be sterile, labeled, mops and gauze. I think it should be the mops and gauzes. We should take count of these gauzes and mops, because in an emergency situation, we ourselves, many times we find some mops or some swabs left in the vagina, which can lead to medical legal complications, implications, etc. So including leggings, linen including leggings, everything should be packed and kept in a tray like this. Next slide, please. Yeah, instrumental delivery set, forceps, ventouse. Next slide, please. Yeah, you should have flash autoclave to sterilize these. So next slide, please. It should be kept, yeah, as you see here, it should not be dipped in some solution, Cidex or Dettol or whatever. No, they should be kept wrapped. Sterile cups of different sizes should be kept wrapped. Forceps should be kept wrapped. So they are separate bundles, okay? And every shift, these should be checked. The instrumental delivery sets and also the vacuum machine, etc. should be checked. Emergency obstetric kit, as you can see, there is a list on the left side of the box. And whenever, I mean, there is an emergency, for example, PPH, eclampsia, etc., all the 28 items are going to be kept in the box, and everything is available. For example, if you need a catheter, the ayah should not be running, or the nurse should not be running to fetch it. If you needed a 16 gauge or 18 gauge cannula, people should not be running helter-skelter to get things. So it should be properly labeled, regularly checked, and it should be kept in a designated place, and components replaced immediately if used. So every shift they have to. PPH tray is another very important thing, which you have to keep. Cervical inspection for, especially for cervical inspection for traumatic PPH, 2 large sim speculum, adequate number of sponge holders, and a large ribbon gauze. It is 4-inch ribbon gauze, a big ball, as you can see on the left side, a big ball of ribbon gauze should be kept for packing the vagina, Alice, scissors, and needle holders. One should not be running here and there, because PPH can be torrential and it can be life-threatening. So tamponade also should be kept in this box, especially the Buckley balloon or the condom catheter should be kept to be used in case there is atonic PPH which is not coming under control. So tamponade procedure is also very useful. So preparedness, I think charts for quick reference, Dr. Sri Lakshmi has covered all these. I think emergency phone number list, including the blood banks, list of blood banks, etc., and obstetricians, registrars, numbers should be there hanging on the wall, anesthetists, pediatricians, even police, because medical legally, we don't know how vulnerable we are going to be even, and also the ambulance and emergency calling bell, the code pink for PPH or code blue for arrest. These should be used in our skills and drills. I think digital clock is also very, very important to make sure that we properly document the time. So handover, it should be written on the board. As you can see, it's a big white board where the handover takes place in front of this board every shift. So it should be written, documented, boards for ease and clarity. It's visible to everybody, and memory is not solely relied on. Tasks done, tasks to be done is clear for every woman. Nurse responsible for each patient can be documented on this board, and duty, OBGYN, pediatrician, anesthetic calls, registrar names with their mobile numbers are written on these boards every shift, which is very important for safety. So documentation, partogram, news chart, additional incident reporting sheet, etc., shoulder dystocia, PPH, all these should be available on the labor ward for documentation easily. We use proformas for our documentation sheets for instrumental delivery, even normal delivery, instrumental delivery, cesarean sections, etc. That makes things very easy, and we won't miss out on any points. That is very important. Documentation is very, very important. We can't take it lightly. Yeah, documentation, it is becoming more and more e-based documentation. Again, Arun and her team have developed this e-partograph, which is very important. I think we should be filling it in labor, and that goes a long way, not only in monitoring the mother and the baby, but also in keeping the labor ward safe and also medical legally safe. Well, central and remote monitoring system is another thing which should come into picture in a big way in our country. Like BPO, that is the business process outsourcing, we should have knowledge, or medical process outsourcing, where we can do remote monitoring of labors and see which baby or the mother is at risk. And that is possible when we can have e-based partogram, e-based CTGs and things like that. So even here, I mean, simple way, central monitoring is possible with Gen3, the device care. So I think it is very, very important that we as obstetricians, if we really want to give quality care to our women, we should keep our labor wards safe. So it is a team which should keep the labor ward safe. It is just not the obstetricians, but also the staff, the ayah, everybody. So with this, I would like to say, please keep the labor ward safe so that you will be safe, the mothers will be safe, and the babies will be safe. Thank you very much. I know I have exceeded a bit of time, but
Thank you,
unfortunately,
Dr. Lata. This was very helpful.
Yeah.
We actually have a couple of questions which we'll take very quickly.
Yeah.
So one of the question which has been asked by Dr. Beena, what is the time gap between attempting IUL between first and second time?
Hello?
Can you hear me?
Yeah, yeah.
In terms of yeah, sorry.
Please, carry on. Srimati, carry on.
I don't think there is any strict criteria about whether you need to give a rest or not, because traditionally there has been the concept that you have to give a 24-hour rest and then start off. I think it depends upon the urgency of the situation. If it is an urgency, I mean, you're inducing because you're worried about the maternal or fetal condition, you will not be able to give a 24-hour gap. So you can do back-to-back inductions. Obviously, if there is no urgency, you can always give a 24-hour gap. Yes, ma'am.
Her another question is, we see nowadays patient being sent home after giving misoprostol for induction and to come once contraction increase. Is it a safe practice to send home like that?
Well, it is debatable. We don't know. I mean, if it is a low risk pregnancy, and if you feel that the patient is intelligent, compliant, etc., maybe. But I know there are centers even in the West who send them home once they have initiated the induction of labor, but it depends on what is the risk and how it has the baby has reacted to the initial what is the initial response to the misoprostol of both the mother and the baby. They are anyway kept for a couple of hours in the labor ward, isn't it, Srimati? Yeah, even if they have to be sent home. Yeah, they just
actually outpatient induction with misoprostol doesn't make much sense, because you have to give that every 2 hours. Outpatient induction with Foley's catheter or outpatient induction with pessary, prostaglandin pessary, which you leave 24 hours, actually makes more sense, because if you're going to give misoprostol, you need to give them every couple of hours, actually, for them to be induced properly. There are a few studies which have been done abroad, as ma'am said, in low-risk pregnancy, putting them a Foley and sending them home, or giving them even a prostaglandin pessary, making sure the patient's CTG monitoring, everything is fine, giving them good information and sending them home and asking them to come in if they're having regular contractions or review at 24 hours. It is being done in select centers with prostaglandin pessary in UK, but the numbers are very few. In Indian setting, I'm not too sure medico-legally where we would stand.
Okay. M. Balachandran is asking, if the mother is gestational hypertension, what is the management done?
Gestational hypertension? Okay, beyond 37 weeks, we tend to induce them. Okay, but again, depends on the favorability, bishops, and also how severe the blood pressure is, whether the fetal growth is all right. So many factors have to be taken into consideration. So the answer to that is probably consider induction after 37 weeks. Yeah.
I think if they are medications,
sorry.
They are not on medications, you can wait a bit longer, isn't it?
Yeah. Then again, depends on the severity. Yeah.
So, Meghna Salim from Amala Hospital, Thrissur, please explain the different type of birth position. I think very quickly we can take it.
It could be squatting, it could be Fowler's, it could be lateral positions, or on the back. Okay, so there are many positions, depends on what the lady is comfortable with. Okay, so in Africa, they use quite a bit of squatting positions. Some of the midwives in UK, they use lateral positions fairly routinely. Niches positions are also, I have seen them. So depends on how, in which position the lady is comfortable, and position she is making a better progress.
Okay, great. Dr. Akansha from AIMS Patna asking, like, how to progress and decide the augmentation of labor.
Yeah, Again, you would take Zung's partogram into consideration. If there is no hurry to deliver the lady, okay, it's a medical, okay, it is not the obstetrician's hurry, okay. So medically, if there is no hurry, I would say we would follow Zung's partogram, and then 6 centimeters you want to perform by amniotomy. And if there are not, if there are no adequate contractions, then probably you would reassess the lady in a couple of hours, and then you want to start her on oxytocin. So starting, doing amniotomy and starting her on oxytocin immediately need not be done.
Okay.
I think something has happened to ma'am's.
Yeah.
So now to answer the question, amniotomy need not come, ma'am has come back.
Yeah. So, as I said, early amniotomy should be avoided.
Okay. So one of the nurse from Kenya, she's asking like how to manage shoulder dystocia.
Sorry?
How to manage shoulder dystocia?
Yeah. Shoulder dystocia, you should predict shoulder dystocia if the descent is poor, and you should take adequate precautions, like you might want to deliver this lady in theater with the anesthetist there, etc. Adequately trained staff to help you if you are expecting shoulder dystocia. And also, you should be well trained with the maneuvers. So, and also, if you are doing a difficult instrumental, then you should be doubly careful. You might need another hand for you to manage shoulder dystocia. So actually what I do is, if you, it's not very well described everywhere, but you can actually, if there is turtling the chin is hitching to the maternal perineum as the head comes out. Okay, what happens in shoulder dystocia? The restitution doesn't happen. See whether you can encourage to restitute. So you push the shoulders to the oblique, yeah, by putting your hands in and just internally trying to rotate it to an oblique position. Okay, so I don't know whether you got it, but anyway, so try to keep the shoulders in the oblique position. That's what happens during actually, yeah, to encourage restitution.
Dr. Shweta from Chennai is asking like how glycemic management in labor for GDM patient can be done.
Yeah, again, depends on how severe. If it is a type 1 diabetic, it's a different ballgame. If they are GDMs, you're safer. Okay, yeah, we usually check the sugars every couple of hours, and most of them, they don't require insulin in GDMs. Okay. If it is a pre-existing type 2 diabetic, again, yeah, we do have a protocol. We check sugars every 2 hours. Either we give on a sliding scale, which is not very ideal, or a simultaneous infusion of dextrose and insulin.
Okay. Dr. Patel is asking,
yeah,
what is
you
the
should
role?
have a protocol. Yeah, okay, especially with in concurrence with your diabetic team.
Yeah, Dr. Patel is asking, what is the role of portable CTG in CS rate, cesarean rate?
If you are not interpreting portable CTG, what do you mean by portable CTG?
When
you
the
mean to say
patient can be mobile.
You mean to say cardless CTG?
Yeah, yeah.
Well, as long as the CTG interpretation is all right and you are able to sort of interpret the graph properly, and the sensitivity of the portable CTG is equivalent to or almost comparable to the traditional CTG, I don't think your section rates are going to be higher. But if you're not interpreting the CTG properly, it's going to put your section rates up.
Let's
So,
take the last question.
Yeah, CTG interpretation is very, very important. Training, case discussions, etc.
Dr. Banwar Patel is asking how to decide whether episiotomy is required or not. Episiotomy.
Yeah, well, it's a very interesting question. It depends on how pliable the introitus is, or and also I think the perineal body, if it is very short, I would be concerned not to give an episiotomy. Okay, so I think these are the two things. And of course, with instrumental delivery, it is better to give episiotomy. Maybe in multips with ventus or occasionally forceps, you might be able to avoid episiotomy. But again, it depends on the experience of the operator.
One of the midwife from Zimbabwe.
Does that answer your question? If you want to add on, Lakshmi, anybody wants to add on?
We are doing more of episiotomies actually. I think the trend is generally restrictive use of episiotomy as and when needed. But generally in Asian population, we have found out that the perineum doesn't stretch as much compared to the Western population. So most of the times in NALEP, we unfortunately end up having to give an episiotomy. But I think we need to beware and see how the progress is happening, how the perineum is stretching, and then take a call whether we need to give, rather than giving it as a routine in all patients. Of course, if you're doing instrumental delivery, it goes without saying, it is always better.
Yeah.
One of the
episiotomy should be prevented, should be avoided.
One of the midwife from Zimbabwe asking how effective is the use of e-partograph in early detection of obstetric complication?
Obstructed labor.
No.
Sorry, what did you say? Obstructed labor.
No, complications.
Complication. Obstetric complication.
Complications.
Use of e-partogram. Okay, yeah. Use of e-partogram is like any other partogram, traditional partogram. You're marking it on what can I say? The interpretation remains the same, except that it can be viewed remotely, and also opinions can be sought real time.
Great.
So
it doesn't, I
wouldn't say that obstetric complications are prevented by, obstetric labors are prevented, and early transfers can take place, etc., because it can be remotely viewed.
And I think because we are required to fill it as, on a real-time basis, we are able to look at the progress better rather than filling it retrospectively. So in
very
important.
Yeah, very important point, because most of the time partograms are filled in retrospectively. So if it can be filled in real time, that is very important. Actually, the complications will be less, if I want to say that.
Dr. Prasanna Nagaraj from Trichy asking like trial of scar selection criteria in your center and experience related to it.
Yeah. Well, trial of scar, if they have had, if they have had symptoms of or signs of rupture, dehiscence, obviously, we don't give them a trial of scar if they are in labor. But If it is a cephalic presentation, age doesn't matter. Macrosomia, I mean, well, again, it's a relative contraindication. So up to 3.8, we usually don't, in a non-diabetic woman, we do allow, but we don't really routinely estimate the fetal weight. So I would say the contraindication to a trial of scar is like any other contraindication to vaginal delivery. So that's what I would say. Yeah, age also doesn't matter. Infertility, years of infertility, etc., also won't matter, really speaking. But obviously, we should be counseling the women or couple, and also we should have a consensus decision rather than just a one-sided decision.
Great. So I think now we have come up to the end of the session, and we are already running 30 minutes late.
Yeah, I know.
Already Sunday evening for everyone.
Yes.
But I would like to thank you, everyone, South Bangalore team, and a very wonderful session. People have really learned a lot. And this video will be live on YouTube. This video will be on YouTube, and we'll be share the link with everyone also. People can go through this video anytime. But I would like to thank Dr. Lata, Dr. Srimati, Dr. Srilakshmi, and all the team. And we'll plan for many more.
Yeah, thank you very much, Arun, for giving us this opportunity. It's a very interesting topic, and I'm thrilled that so many of you have participated from all over the world. It really humbles me. Yeah, humbles us. Yeah, thank you very much. And I hope we will be of, I mean, this has been of some value to you, and I hope we will be of some assistance to you in developing some more interesting devices.
Yeah, looking forward to, yes. Thank
Thank you.